So with that, I'm going to talk about the TAVR and stroke, as Sushil says they're blaming me from not using the valve. So I said I have few questions that I planned so that at least we understand. One question is, how common is the stroke in contemporary era? And this is a common question that a lot of people ask. And if you look at this whole hype started with the Partner 1A trial. So in the Partner 1A trial, if you look at the stroke was 5.5 versus 2.4. So if compared to surgery, the strokes were higher in the TAVR group. And this is what led to the first New England Journal editorial by Dr. Schaff, who says that, TAVR is going to have a problem because there is going to be higher stroke. And that's why a lot of people started, including myself, Sushil, to say how we can prevent stroke. This was the initial data where there was no primary endpoint of stroke. So none of these patients were examined by neurologists. So these were self-reported or reported cases of stroke, and surgical strokes were underrepresented in our experience. So when we combined all the trials, partner trials, subsequently, and we looked at the stroke, it was clear that the TAVR-related stroke was actually same or less compared to the surgical stroke. So stroke was not higher with TAVR, and actually the major stroke, if you look at it, was 3.9 versus 2.2, was actually lower compared to that what we saw in the surgery group. So this is very important. So at least that part is done. But now people say that, okay, well, the stroke is not higher than surgery, but is that a gold standard? Surgery is a gold standard? No, because when patients come to the cath lab, they want to say that their stroke should be like cath lab procedures, like PCI, 1 in 1,000 or 1 in 500. And this is not what it is with TAVR. So where do we stand? So if you look at all the strokes in the recent literature, relatively recent, then if you look at it, it is about 1.7, 0.6 to 1%, depending on the low-risk trials. If you take higher risk patients, the stroke risk is higher. If you look at the Sentinel trial, where the Sentinel trial is the protected TAVR trial, it is 30% high risk, medium risk, and intermediate risk patients. And the stroke risk in the control group was 2.9%. However, when we look at the TVT registry recently, the stroke risk was 1.4%. So just to keep in mind that at least the self-reported stroke risk is about 1.5%, and if you do the trial, it is about 3%. So this is an important information to keep in mind. However, if you look at the strokes, people who have strokes, the mortality is high, 12.7%. And 30-day mortality is 16.7%. This is from the TVT registry we published in JAMA a few years ago. And if you look at these patients, they don't go home, in the sense that there are 79% of the patients without stroke go home, whereas only 36% of the patients with stroke go home. So they have very important comorbidities with stroke. If you look at the impact of survival long-term, even in the partner trials, there is at least half survival, 47% versus 82% in the transfemoral people who had stroke versus 53 and 80. So there is a mortality risk in the patients who develop stroke. Then with Sushil, we did the first trial where we showed that 99% of the filters, when we put the Sentinel filters in the carotids, 99% of them have material inside. So that means that we are at least catching something in these filters, and the filters were extremely safe in the sense that when we put the filters versus we did not put the filters, there was at least not a higher risk of stroke, or there were no vascular complications, or even the renal failure or need for contrast time, everything else was acceptable, and there was no higher risk of putting this device. So I thought I'll just review very briefly the protected TAVR trial, what is not covered, what are the other data that are emerging, and then some recommendation. So the protected TAVR trial we designed by the idea that we wanted to say, this is during COVID, we wanted to do the trial where we say that the patients we just follow for until discharge, and the primary endpoint is 72-hour stroke. So very simple trial, 3,000 patients. If you consider the fact that all the trials that we have done for TAVR never had 3,000 patients. This is an ancillary device, and now we are doing a randomized trial with 3,000 patients. So this is a relatively large trial. Now you know that the BHF trial is going to enroll 8,000 patients. So anyway, we did 3,000 patients, 1,500 in each group. Neurological exam was done in all patients. And then we had all the important ways of determining how the stroke was, disabling or not, in all the patients. Randomization worked. There were slightly more women in the CEP group. And as I said, we had about one-third, and one-third patients with high, intermediate, and low-risk patients. And balloon expandable valves were used in 2/3 and self-expanding valves in 1/3 of the patient. And pre and post dilatation was done in 40 and 25% of patients. And the primary endpoint was negative, so it was 2.9 versus 2.3% overall stroke risk. However, if you look at the disabling strokes, 1.3 versus 0.5%. And this was different, however, this was a secondary endpoint. So in a rigorous way of presenting the trial, we said that, the primary endpoint negative, this is a secondary endpoint, and this is the reason why it's hypothesis generating, but not really proving that this device works for the disabling strokes. And the mechanism is also important. So when you're saying that there's a disabling stroke, what are the reasons why people are having disabling strokes? So they are mostly ischemic strokes that this device is preventing. And of course, some of the patients, this is an important table to keep in mind. So when we say the patients who develop disabling strokes despite having sentinel, why did they develop disabling strokes? So 2 of them had hemorrhage. The 5 people that you see in between had really messed up complications with TAVR, like embolized valves, all kinds of things that were really tragic. Or they had unprotected vessels, which had stroke. So the device was actually working in all these patients, and it was a limitation of the device. So if you improve the device, we have a better device, there is a chance that we can help these patients. Only 1 patient had a TAVR in the left MCA territory, TAVR-related, uncomplicated TAVR with a left MCA stroke. So only in 1 patient, it was not explainable why this happened. And then these are all the subgroups, and as you look at the subgroups, it's clear. If you look at one subgroup that is, I think, important to know, that US, so 1,800 patients were in the United States, the last one. The 1,800 patients were in the United States. These are all strokes and disabling strokes, both were reduced. So primary endpoint and secondary endpoint was positive in this subgroup analysis. So, it's a subgroup analysis. So again, this is a limitation, but in this 1,800 patients, this was a positive result. What was not covered, we also looked at similarly that patients were discharged. So if here's a major stroke, then we would know that how many patients were discharged home or not, how many people were in the ICU. All these were consistent with the idea that there were less disabling stroke with sentinel. What happened since then? So there are several other data that came out. So there is a TVT initial registry data that also showed that the mortality in the patients who were using the CEP was less, 1.4% versus 2.2%. So again, the major strokes were prevented and the mortality was less. In the NRD readmission database, again, the hospital death in the patient with stroke was less, 6.3 versus 11.8%, very similar to what we saw in the other analysis. This is from Cleveland Clinic, so we also looked at our own data to say that before using the CEP device and after using this, we had our own 3,000 patients. So we used all our 3,000 patients. And if you look at the 1,000 patients without the CEP and 1,800 with the CEP, there were 15 strokes in the 1,000 patients and 8 in the CEP arm. And if you look at that, the major strokes or disabling strokes were reduced. We called it major because there's NIH stroke scale that we used. Rankin score was also less. And there are 4 patients who died of 15 when they developed stroke versus none of them died after we started using CEP. So all the strokes were non-fatal, at least when we had the CEP used. TVT analysis we recently did again to look at after the rolling out of the protected TAVR data. And here now, with the propensity score matching, all strokes as well as disabling strokes were reduced modestly, but they were reduced. But remember that the overall stroke rate was 1.4%, 1.5% compared to 2.9% in the Sentinel trial. Instrumental variable analysis showed that the disabling strokes were reduced, but not the overall strokes, very similar to the protected TAVR. So what do we do? So what I'm saying is that it is very simple to do the Sentinel device. It goes to the radial artery. It is not a very difficult procedure. It takes literally, we are running this, and literally it takes, I'm sorry about this, it takes literally a few minutes to put the device in, and both the arteries are protected except the left vertebral. So we are using it in all our patients. These are our data from 2018 to 2023. We are doing about 600 to 700 patients every year. The mortality is low, but also the stroke rate is 0.5% with the use of the Sentinel device in all the patients. So this is a very important part to say that at least it's simple enough to do. So we are doing this. There are several new devices that are being tested, and all of these devices are either radial devices, groin devices, and all this, as you know, that these devices have different kinds of endpoints designed into them. Some of them can capture the debris, some of them cannot, some of them are MRI endpoints, some of them are clinical endpoints. And the protected TAVR trial, the BHF protected TAVI trial, is currently enrolling. They are doing 8,000 patient trial. Their hypothesis is from reducing the events from 3% to 2%. We designed the Sentinel protected TAVR with a 4 to 2%. So this is, I think, is a better number with the BHF TAVI trial. Of course, they have a little bit of a difference that they are not having all the patients seen by neurologists. Only the patient who are symptomatic will be seen by neurologists. So maybe their event rate may be even smaller than that. It is a higher risk population. So far, the mean age is 82 years. Because in United States, when we did the trial, the device was approved, so there was some inherent bias in enrollment. So this is the trial that is ongoing, and we are looking forward to it. They have already enrolled close to 6,388 patients of May 4th. So 1,400 patients left. I'm sorry, my calculation was wrong because I had a different number before. I can still subtract. So what are the subgroups that are important that we need to know? We have data for all of this, not really published. So valve-in-valve, bicuspid aortic valve, prior stroke, and history of atrial fibrillation. These are the subgroups from the TVT registry or from the NRD database seem to have benefit from the use of CEP. Again, this is a retrospective subgroup analysis, but if you are going to look for some patients where there is a benefit, these potentially are the patients. So in my mind, stroke is still a clinical problem, although the stroke risk is lower. Sentinel use has been associated with a lower risk of disabling or major strokes, at least from all the data that I presented to you. The device is extremely safe. The stroke remains largely unpredictable, and this is an important message to keep in mind, that some people believe that in the low risk patients, they don't want to use the device because, but these are the patients that most likely would benefit from it, because if you have a low risk patient who develops stroke, it is really a terrible thing. And as I said, that these are the 4 subcategories. I think that you should consider Sentinel device if you are going to restrict your use. And several second generation devices are being tested, so stay tuned and you will have more data to look at in next 1 year or so. So thank you for your attention. We have some time for questions.